next up, we have Dr. Steve Naymagon. Steve is an assistant professor of medicine here in our division of gastroenterology. And Steve has one of the most unenviable tasks, and he is our small bowel expert. So he does capsule endoscopy, he does deep bowel enteroscopy, and he uses these tools. Some of the things he uses these tools for is to identify or manage patients with obscure GI bleeding. So he's going to talk to us about finding the needle in the haystack. Steve.
Thanks, Chris. You know, when you said I have one of the most unenviable jobs, I thought you meant I was going to be working with you. But thank you very much for inviting me to talk about this subject. Thank you for the catchy title for the talk. So what I'm going to try to do is start with a little bit of background on small bowel bleeding, and then try to go through this in a systematic way in demonstrating cases. Try to get through all the cases if time allows. Oh, you haven't started. Should I start my timer? Sure. All right. So the background. So the first thing we should do is define terminology. And the traditional definition of obscure GI bleeding is the presence of bleeding in the GI tract with a negative EGD, colonoscopy, and a small bowel series. And so that sort of left the small bowel as this big bloody black box that we didn't really have access to. But this traditional definition was really adopted prior to the advent of some of the new technologies that we now have for assessing the small bowel. So with the advent of these new technologies, most of the small bowel can actually be visualized. So probably a more apt definition for small bowel bleeding, for GI bleeding, would be to define it anatomically. You have upper GI bleeding, which is accessible with an endoscope, colonic bleeding, obviously with a colonoscope, and then small bowel bleeding is everything in between. And the term obscure GI bleeding should really be reserved only for cases of bleeding where a source cannot be identified despite complete visualization of the GI tract, whether it be by radiologic imaging or by capsule. So how common is this? Well, EGD and colonoscopy will identify a source of bleeding in approximately 90% of the time. So that leaves about 10% of cases that are found in the small bowel. Of those 10%, approximately 75% can be diagnosed with capsule or with other modalities. So only about 2.5% of cases of bleeding are really truly obscure. So having said that, the rest of the talk we'll talk about focus on cases of small bowel bleeding specifically. So case 1. A 68-year-old woman with hypertension is noted to have microcytic anemia on routine blood work. She denies noting frank blood in the stool or melena or black stool. On exam, she is Hemoccult positive. Her iron panel is consistent with iron deficiency. She undergoes EGD and colonoscopy, which are normal. And she's referred for further evaluation for her anemia. So what does she have? So she has occult GI bleeding, and presumably this is coming from the small bowel, but there is a question mark there. So what can you offer this patient? Well, you have a number of diagnostic options, a whole laundry list. So you can do a second look endoscopy, you can do a push enteroscopy, a capsule, a device-assisted enteroscopy, enterography, angiography, nuclear scan, intraoperative enteroscopy. So a lot of different options. So the way that I'm going to approach this is by focusing on the ACG recommendations that came out a couple of years ago, which were really fantastic and really worth reading through. So when looking at a patient where you suspect small bowel bleeding, whether it be overt or occult in this patient, the first step the ACG proposes is potentially repeating an endoscopy. So is this really necessary? So a number of studies have looked at the use of second look endoscopy, and they've used either push enteroscopy or capsule or double balloon enteroscopy to basically answer the question, well, what percentage of lesions that we see here could have been detected on an upper or a lower repeat exam? And as you can see, the diagnostic yield is quite variable, from as low as 3% to as high as a quarter of patients. So it seems like it could be a reasonable thing to do. So how do you decide? So we basically try to answer the following questions. Was the last exam recent? Was it done a year ago, or was it done a month ago? What was the quality of the exam? Do you trust the endoscopists who did it? Was the preparation good? What were the findings? Was it completely normal, or were there some suspicious lesions? And what's the character of the patient's bleeding? So if you decide to do a second look, should you do a push enteroscopy? This comes up a lot. So a number of studies have looked at this as well. One of the more recent studies was a retrospective study that looked at patients undergoing both a push enteroscopy with or without a capsule. They had 155 patients who had a push. 74 of them underwent both push and capsule. You can see the indications were quite variable, some bleeding indications, some other indications. And what they found was that the diagnostic yield for push enteroscopy for finding a source of bleeding was about 30%. And another interesting point was that in patients with a prior capsule, there were no additional or missed lesions detected by push enteroscopy. So this study sort of suggested that the diagnostic yield is relatively low, and we'll see it is significantly lower than some of the other modalities we have for looking at the small bowel, and you're not really picking up many additional lesions. So what is the role of push enteroscopy? So this study and a bunch of others have estimated a diagnostic yield of about 30%, which is relatively low. So I really think that push enteroscopy should be used as an adjunct for patients with a negative capsule who you really still suspect a proximal upper GI bleeding source. And even though this sort of goes against what this study showed, I do believe that capsule is less sensitive in the duodenum as the pill just kind of swoops around the duodenal sweep. And doing a push enteroscopy may be helpful in this case. And also therapeutic as a therapeutic adjunct to a capsule if you find a lesion in the proximal small bowel. Okay, so now we've done our second look endoscopy, and now we're pretty confident that this is a small bowel bleed. So what is the next step? Well, unless you're suspecting a mass lesion or an obstruction, the next step is really capsule endoscopy. And the ACG does promote capsule endoscopy as the test of choice for assessing the small bowel. And there are a number of reasons. It is non-invasive. It is effective in visualizing the entire small bowel in approximately 80% of cases. And the diagnostic yield is actually fairly good. The overall range among numerous studies of capsule ranges from around 40% to over 80%. And a number of meta-analyses and systematic reviews have also been done. And the diagnostic yield is probably somewhere around 2/3, and which is what I tell most patients, that with this test, we have about a 2 out of 3 chance of diagnosing what the problem is in your small bowel. So now you've done your capsule, and it's negative. So let's look at the other side of this algorithm, and the ACG supports the use of CTE or MRE, which typically we think about in small bowel Crohn's disease, but it does have a role in small bowel bleeding. And the reason is that CT enterography allows for really great resolution of the small bowel lumen and mucosa, and in some cases may actually also allow you to see blood in the lumen. But here's the punchline. It has a very high sensitivity for detecting mass lesions and mural lesions, which could be missed by capsule. And a number of studies have shown that there's a significant incremental yield for mass lesions over capsule using CTE. And as someone who reads a lot of capsules, the thing that I'm most concerned about is missing a mass. And these things can sometimes be very subtle, and that's why adding this as a complementary modality can really be very, very helpful. Okay, so you've done your capsule and your CTE, and if you find a lesion, you'll of course target it, whether it be with enteroscopy or surgery. But what happens if both studies are negative? What do you do next? Well, the fact is that a negative capsule is actually a very, very good test for ruling out small bowel lesions. The negative predictive value in various studies ranges between 83 and 100%. And the rebleeding rate after a negative capsule is actually very low. So it's a very good test for ruling out bleeding. But there is a false negative rate for this exam. And some studies quote rates as high as 11% for any small bowel lesion and almost 20% for mass lesions. So your decision as to what to do next after a negative capsule is really going to depend on how the patient is doing. So if there is evidence of ongoing bleeding or suspicion for a mass lesion, you should do the workup again, whether it be endoscoping the patient again, repeating a capsule, or getting more cross-sectional imaging. And there is literature on the increased incremental yield of repeating a capsule after a negative exam. However, if there's no evidence of ongoing bleeding, patient's doing fine, the ACG and the European Society both support a wait-and-see strategy. So that rounds out our algorithm for the approach to suspected small bowel bleeding. All right, moving on to case number 2. So, an 84-year-old man with a history of diabetes, end-stage renal disease and dialysis, and coronary artery disease requiring drug-eluting stents presents to the ER with weakness and dark stool for about a week. His medications include aspirin and clopidogrel. His admission vital signs are a blood pressure of 100/60 and a heart rate of 80. He has melanoma on rectal exam, and his hemoglobin is 8.5. Patient is stabilized and taken to the endoscopy suite. His EGD reveals some gastric erosions, but no clear source of bleeding, and his colonoscopy is normal. Over the next 24 hours, the patient remains stable, but his counts continue to drift down slowly. So this patient has overt subacute GI bleeding, which we can be pretty confident is from a small bowel source based on our normal upper and lower exam. So what diagnostic options can we offer this patient? Well, it's basically the same laundry list that we went through before, except that now we've eliminated our need for a second look, so to speak. So what does the ACG recommend we do in this situation? So for a suspected subacute ongoing small bowel bleed, first step obviously is resuscitation, and the second step is either a capsule or a CT enterography according to the ACG recommendations. So how good is capsule in acute overt GI bleeding? A number of studies have looked at the diagnostic yield of capsule based on the timing of the exam. And as you can see in all of these studies, the diagnostic yield drops significantly as you go from an emergent exam to an urgent exam to an elective exam. And the diagnostic yield for an emergent capsule, which is defined differently in different studies, is really between 70 and 90%, excluding this one trial, which really has had inexplicably low diagnostic yields. They've also looked at the efficacy of capsule in the inpatient setting specifically for acute bleeding, and most of the time these capsules were done within 48 hours of a negative EGD and colon, and they found either blood or a lesion between 62 and 90% of the time, and that translated into a very significant therapeutic yield, whether it be endoscopic, radiologic, or surgical. So I do think that capsule endoscopy in this setting is the go-to test of choice. CTE we don't use quite as much, but it is something to consider if a patient has ongoing bleeding with a negative capsule. So, of course, if the capsule is positive, then the next step is proceeding to deep enteroscopy and providing definitive therapy. So deep enteroscopy, there are multiple different techniques available to us. The one that's been around the longest is double balloon enteroscopy. And so let's talk a little bit about the performance characteristics. So with double balloon, total enteroscopy can be achieved between 60 and 86% of the time in looking at various studies. The diagnostic yield for small bowel bleeding ranges between 50 and 80%, with a pooled meta-analysis showing a yield of about 55%. And successful intervention can be offered between 40 and 70% of the time. Complication rates are low. Pancreatitis is very, very uncommon, and perforation risk is comparable to that of colonoscopy. But one thing to really note that's really important is that rebleeding rates after therapy with a double balloon enteroscopy is up to a third at 1 year. And this is something that really haven't made a dent in since having this technology available. And the reason for that is that most of these lesions that we treat are vascular lesions, which tend to be multifocal and recur. So, diagnostic yield of double balloon. It's been compared with capsule, and as you can see in 3 meta-analyses, the diagnostic yields are almost identical. If we look a little bit closer at the most recent meta-analysis, this was a study that included 10 different studies using both capsule and double balloon for obscure GI bleeding. The pooled diagnostic yields for capsule and double balloon were essentially the same. But if you tease out a little bit and look at patients who had a double balloon enteroscopy after a positive capsule, your diagnostic yield goes up to 75%. And patients with a negative capsule, way down to 27%. So it really begs the question, should a capsule always be done first before a double balloon enteroscopy, or is there a role for going directly to enteroscopy? And there's an argument to be made for both. Advantages of doing capsule first, of course, is that it's non-invasive. It can be done relatively quickly. It has a high diagnostic yield, especially in the acute setting, as we've shown. It has a high negative predictive value, and it helps guide the therapeutic approach. But there are disadvantages, of course. Capsule obviously has no therapeutic capability. If it's positive, it will inevitably lead to an invasive procedure, even though it's not invasive. It does take time to run. You've got to have the patient swallow the capsule got to run, then you got to read the capsule, so that delays the intervention by sometimes a day or more. And in terms of guiding therapeutic approaches, the majority of lesions on capsules are actually found in the proximal small bowel, so the anterograde approach will be the chosen approach most of the time. And of course, you're adding another test, which increases the cost. So how effective is, so I'm going back to our, just to comment on our approach to things. If a patient has subacute slow bleeding, we usually do a capsule first because of the high negative predictive value and possibly having the patient be spared of an invasive test. However, if there is brisk ongoing bleeding, maybe going to double balloon enteroscopy first or deep enteroscopy first would be the way to go. And how good is it? This was a retrospective study, 120 patients who underwent either urgent or non-urgent double balloon enteroscopy for bleeding. Urgent was defined as under 72 hours of the last bleed. And they found that the diagnostic yield in the acute setting was 70% versus 30% in the elective setting. And the endoscopic and overall therapeutic yields were significantly higher in patients who had the procedure earlier, and the rebleeding rates were significantly lower. Just a word about the choice of modality. There are several ways of doing deep enteroscopy, and they have been compared. This is a recent systematic review assessing the efficacy of double balloon enteroscopy compared with single balloon enteroscopy. And they included 4 trials of 375 patients. And the punchline here is that there was no difference in diagnostic yield, therapeutic yield, failure rates, adverse events, or complete enteroscopy rates. So I think the bottom line here is that you have to use the technique that you're most comfortable with and that you have expertise with at your center. So after we've done our enteroscopy, if it's positive, we treat accordingly. However, what do you do? Again, just to highlight the fact that this is probably a two-way street. You can do enteroscopy before capsule or after capsule. And what do you do if it's negative? Well, then we really need the help of our radiologist. And the first test of choice that we use here is CT angio. So CT angio has remarkably high sensitivity for detecting active bleeding and very high specificity. A negative CT angio really implies either the cessation of bleeding or very slow bleeding, has a negative predictive value of nearly 90%. And in these cases, with a negative CTA, a strategy of watchful waiting may be a reasonable approach. And the reason for that is that the incidence of a positive angiography after a negative CTA is incredibly low. So you can spare some of these patients angiography. However, if your CTA is positive, then of course you'll go to angiography and transarterial embolization, which of course offers the advantages of having directed therapy. You have the option of using provocative maneuvers, and you have the ability to localize lesions and mark them for surgery if the bleeding cannot be controlled radiologically. The diagnostic yield for angiography is very high, in some studies up to 77%, but it really depends on having active bleeding, significant bleeding, or a positive CT angio. But of course, we always are concerned about this modality because of the potential for complications. Most worrisome, of course, is thromboembolic events and bowel infarction. So that rounds out our approach to the subacute small bowel bleeder. And I have a few minutes left, and we'll try to get through case 3, which is a 75-year-old woman with coronary artery disease and atrial fibrillation who presents with presyncope and hematochezia. Her medications include aspirin and warfarin. Her vital signs are 80/50 with a pulse of 110. Abdomen is benign, and she has maroon stool in the rectal vault. Her hemoglobin 7 and INR is 3.1. She is stabilized, receives a rapid bowel prep, and undergoes EGD and colonoscopy, revealing maroon and red blood throughout the colon and ileum, but no source is identified. Patient continues to pass red blood and requires 3 units over the next 24 hours. So this patient is having an overt brisk GI bleed, presumably from the small bowel. And again, we have the same menu options. So what do you offer this patient? Well, in these really acute bleeders, the first step should really be a radiologic study. I think that red cell scans are not terribly helpful, so most of the time we proceed with CTA, and then if it's positive, to angiography and embolization. However, if the patient is unstable, perhaps going to angiography straight and bypassing the CTA would be a reasonable approach as well. So CTA, we mentioned the sensitivity and specificity of it, but in this prospective study of 26 patients with acute massive GI bleeding who underwent a CTA followed by conventional angiography, they found that the CTA detected extravasation in 21 out of 26 patients, was able to localize the bleeding effectively in almost 90% of patients, and the location of contract extravasation on CTA corresponded exactly to that of angiography in all of these patients. So again, a very, very effective study. What about angiography in acute massive GI bleeding? In this retrospective analysis of 70 consecutive patients with a brisk GI bleed who underwent angiography and embolization, they had a technical success rate of 98%, a primary clinical success rate of 71%, and a secondary clinical success rate of 78%. There were 3 patients who had bowel infarction. And they did identify predictors of failure or rebleeding, and that was a significant hemoglobin drop, coagulopathy, upper GI bleeding, and more than one embolized vessel. So what if the radiologist can help us? Is there a role for endoscopy? So double balloon enteroscopy has been used in cases of massive GI bleeding. This is a relatively recent study where emergent double balloon enteroscopy was used on 27 patients with severe overt GI bleeding, defined as less than 24 hours of the bleed. And these patients were found to have doulophores, angiodysplasias, ulcers, tumors, and diverticula in the small bowel. And 23 lesions were amenable to endoscopic therapy, and 21 out of 23 were successfully treated. So emergent DBE is a viable option in patients with acute overt small bowel bleeding. It is important to point out that a lot of patients required more than one procedure, and the rebleeding rate, as we mentioned before, is not insignificant. Of course, if all else fails, we can go to intraoperative enteroscopy, which I'll skip through relatively quickly, and it's not our favorite because it has a relatively very invasive. Still, there is a recurrence rate and has a high mortality and morbidity. And with that, thank you.